Now we go on to the cervix. Cervical pathology can be divided into precancerous and cancerous lesions. Precancer includes dysplasias, and if the dysplasia involves the entire thickness of epithelium down to the basement membrane, then it is referred to as carcinoma in situ. Now, invasive carcinoma is when there is an invasion past the basement membrane, allowing access to the blood vessels and lymphatics, which can then lead to metastasis. If there is a linear basement membrane, so notice how in cervical dysplasia here, the full thickness of the cervical epithelium is involved, but there's no penetration of this basement membrane. See how it's very linear? How it's very continuous? So that's carcinoma in situ. If we had invasion through this basement membrane, we'd have invasive carcinoma. You can see that although there's dysplasia of the epithelium, there's still this continuous basement membrane, the same as with normal cervical histology. Now, HPV 16 and 18 are associated with the development of cervical cancer. The USMLE really likes you to know this. And cervical dysplasia is characterized by the presence of coilocytes, which are noted on Pap smear. These are large cells that are seen with abundant cytoplasm and irregular nuclei. And it's HPV 6 and 11 that are associated with condylomata acuminata, which is another name for genital warts. So 16 and 18 for cervical cancer, 6 and 11 for condylomata acuminata genital warts. And it is a history of multiple sexual partners plus no Pap smear that are the biggest risk factors for any cervical pathology. The mechanism by which HPV 16 and 18 lead to cancer is a good opportunity for us to refresh our memories on the neoplasia section of pathology. HPV 16 produces a gene product E6 which inhibits P53. HPV 18 produces a gene product called E7 which inhibits RB. Now, do you remember what P53 and RB are responsible for? Right. They are tumor suppressor genes that act to stop the cell cycle from progressing. So if we inhibit these inhibitors, we get unregulated cell division or cancer. The bottom line is that you need to remember E6 and E7 are the names of the proteins produced by HPV 16 and 18 respectively, and they inhibit P53 and RB respectively. Moving on to the endometrium. We have a condition known as endometritis, which, as you can tell from the name, describes inflammation of the endometrium. This is generally associated with retained products of conception following any form of childbirth, death of a fetus, or prolonged presence of a foreign body. This retained material serves as a nest of infection for bacteria from the vagina or GI tract, leading to abdominal pain, fever, uterine tenderness, menstrual abnormalities, and infertility. It should definitely make an appearance on your differential whenever you see this constellation of symptoms in the setting of recent childbirth, miscarriage, or abortion. Treatment involves use of appropriate antibiotics, such as gentamicin, which is an aminoglycoside, and clindamycin. Gentamicin inhibits 30S ribosomal subunit, clindamycin inhibits the 50S ribosomal subunit. Another important and common condition, called endometriosis, is a condition where endometrial tissue is found in locations outside of the uterus. This tissue behaves like normal endometrial tissue despite its ectopy, and thus you have cyclic menstrual bleeding from these sites. The most common locations include the ovaries and the cul-de-sac in the peritoneum, otherwise known as the pouch of Douglas. So can you recall from your anatomy where the pouch of Douglas is? This is the space that is located between the uterus and the rectum. When you have endometrial tissue implanted there, the patient may have painful defecation during menstruation. You can also get endometrial tissue at either sites on the peritoneum or, less commonly, the diaphragm. When ectopic endometrial tissue in the ovaries bleeds and clots, they become enlarged and tender, forming so-called chocolate cysts. This image shows ruptured chocolate cysts in the left ovary of a patient. Typically, the symptoms you're looking for include dysmenorrhea, which is painful menses, or dyspareunia, which is painful intercourse, and infertility. The uterus is also normal-sized in endometriosis. Recall, there's nothing wrong with the uterus in endometriosis. It's just merely endometrial tissue implanted outside of the uterus. Now for adenomyosis, you need to know that this is endometrial tissue growing inside the myometrium of the uterus, and the uterus is large and bulky. Now, the USMLE loves you to know the contrast between endometriosis and adenomyosis. It's simple, but don't mess it up. Endometriosis is the presence of endometrial tissue growing outside of the uterus, whereas adenomyosis is the growth of endometrial tissue inside the myometrium, the muscular layer of the uterus. And the uterus is large and bulky, whereas in endometriosis, the uterus is of normal size. Now, an adenomyoma, also known as a polyp, is merely a benign tumor of endometrial glands and smooth muscle, and is a type of adenomyosis. That's all you need to know about adenomyoma. It's merely a benign tumor of smooth muscle and endometrial glands. Now, endometrial proliferation. Endometrial hyperplasia is an abnormal endometrial gland growth that is a direct result of excess estrogen stimulation. Now, endometrial hyperplasia is more common in any state that causes unopposed estrogen, including anovulatory cycles, hormone replacement therapy, polycystic ovarian syndrome, and granulosa cell tumors. In a woman's menstrual cycle, pre-ovulation is associated with an estrogen-dominant state, whereas post-ovulation is associated with a progesterone-dominant state. So as a result, if a woman is having anovulatory cycles, like in polycystic ovarian syndrome, then she does not have the transition from estrogen to progesterone, so estrogen stays unopposed. With hormone replacement therapy, you have a situation where you're receiving exogenous estrogen, and with granulosa cell tumors, as we'll see when we talk about ovarian stromal cancer, these lesions secrete estrogen. Again, it doesn't matter where it's coming from. All that matters is that you've got a persistently high estrogen state. And when endometrial hyperplasia finally becomes adenocarcinoma of the endometrium, it most often presents as postmenopausal vaginal bleeding. Now, if you get a question where the patient in her 50s to 60s, that is past menopause, has new onset vaginal bleeding, it is endometrial cancer until proven otherwise. And since it is also, in fact, the most common gynecologic malignancy. This image shows a typical endometrial adenocarcinoma presenting as a polypoid and fungating mass in the body of the uterus. Now, the risk factors for endometrial carcinoma are the same as those for hyperplasia prolonged unopposed estrogen. But just as a side note, endometrial cancer actually has by far the best prognosis of all the major gynecologic malignancies, better than cervical and ovarian cancer. Can you think of why patients who have never been pregnant or who have early menarche and late menopause will have increased risk for endometrial cancer? Again, it all has to do with the estrogen-progesterone balance. During pregnancy, the predominant hormone is progesterone, so it is protective against endometrial cancer. Early menarche and late menopause extend to the reproductive time period when estrogen is high. During pre-menarche, patients have immature ovaries and have low estrogen, whereas postmenopausal women have non-functional ovaries and also low estrogen. Now for the flash quiz. What is the main difference between endometriosis and adenomyosis? That's right. Endometrial tissue outside of the uterus is endometriosis, whereas endometrial tissue inside the muscular layer, the myometrium of the uterus, is adenomyosis. Leiomyomas, also known as fibroids, are actually the most common tumor in females, and they're benign. These smooth muscle tumors are estrogen sensitive. They grow with pregnancy and shrink with menopause, as do the symptoms of extensive fibroid disease, especially pain in that region. As you can see from the images, they look like a ball of muscle. They tend to occur most often in younger women and have a greater frequency in African Americans. They usually present with abnormal uterine bleeding. On histology, they have whorled or twisted patterns of smooth muscle bundles. You can see the whirling here on the gross pathology as well. The word whorled is another good descriptive medical buzzword you'll want to keep in mind in the context of leiomyoma. Now, as I just mentioned, uterine fibroids are benign and they do not lead to leiomyosarcoma, which are bulky, irregularly shaped malignant tumors. Notice in the image the spindle-shaped tumor cells that resemble smooth muscle but include abnormal features such as increased nuclear to cytoplasmic ratio, mitotic figures, etc. Remember that leiomyosarcomas are not a progression from leiomyomas and are not associated with them at all. Leiomyosarcomas are also more common in African Americans, but they tend to occur at a later age than leiomyomas, that is, middle-aged women. These tumors are highly aggressive and often recur when removed. Moving on to some statistics for all you numbers people out there. In terms of gynecologic tumor epidemiology, the most common gynecologic cancers are endometrial, then ovarian, then cervical. While cervical cancer used to be the most prevalent, the advent of the Pap smear has allowed doctors to catch and treat cervical precancer, causing the prevalence to drop dramatically, at least in developed countries. In terms of mortality for gynecologic cancers, the order from most to least deaths per case is ovarian, then cervical, then endometrial. Ovarian cancer can be really bad, especially because they are typically silent and asymptomatic until they are at stage 3, at which point they have spread outside the pelvis and have a generally poor prognosis. A couple of other thoughts here. Don't confuse gynecologic cancers with all cancers in women. Remember that in women, the most common cancers are breast, then lung, then colon cancer. But in terms of mortality, it's lung, then breast, then colon cancer. So in women, breast cancer is most common, but lung cancer is the most deadly. Now, premature ovarian failure is another name for early menopause. It's now considered more commonplace to call it premature ovarian insufficiency, since the term failure appeared to put a more judgmental effect on the patients. You might see it either way. The average age of menopause is around 51, but menopause is not technically considered abnormal unless it occurs before age 40. Now, as in menopause, the gonadotropins LH and FSH are elevated in premature ovarian failure, but the ovaries do not respond, and therefore estrogen levels are low. Remember hypogonadotropic hypogonadism that we talked about previously? Well, in contrast, premature ovarian failure is called hypergonadotropic hypogonadism because you have the anterior pituitary signaling the ovaries with LH and FSH as hard as it can but with no result. So how is premature ovarian failure a bad thing? Well, along with infertility, early menopause also puts women at increased risk for osteoporosis and heart disease, since, as you know, estrogen is normally protective against these diseases. The condition is most often idiopathic, but in some cases it can be caused by autoimmune disorders. On the boards, anovulation may show up as part of an infertility case scenario, so you may want to keep the possible causes of anovulation in mind. Of the list, polycystic ovarian syndrome is the most common, so with minimal information about the patient, you have the best odds that this is your diagnosis. We'll discuss it next. Another common cause is eating disorders, particularly anorexia or bulimia, because extremely low BMI leads to loss of pulsatile GnRH release from the hypothalamus. Watch out for hints about abnormal weight loss, dieting efforts, or secretive eating patterns. These patients' amenorrhea is reversible with restoration to a healthy weight.